And I was kindly given these slides from Vincent, Liberty, and Jacques Devierre, and so I thank them for that. So this is the agenda for my talk. We're going to talk with the introduction, setting the problem. I'm going to give you an overview of all the different endoscopic techniques for weight loss, as well as what we have available now for metabolic endoscopy, which is duodenal resurfacing. Some slides about resources and how to invest and how we're going to go on further on, and we're going to finish with a take-home message. So to set the problem, obesity is a chronic relapsing disease. These are the definitions which we know well. So overweight is a BMI between 25 and 30, and obesity is defined as more than 30. It's 37% of the US population has a BMI over 30, so it's a real health problem. And it's also linked to over 260 medical comorbidities. Of course, primary prevention is the key. Education with lifestyle intervention is first line, but this doesn't seem to be enough. And there is also a lack of standard of care for individuals with a BMI between 30 and 40. We know above 30 is surgery, but between 30 and 40, it's still a gray zone. And this leads lots of opportunity for development of multiple endoscopic devices and techniques. So the problem is also that, as you see, this is a major health issue. We have 650 million obese people in the world, but only a minority of them will have treatment, will have these surgical interventions. Less than 1 out of 1,000 obese people will have a surgical intervention. These are worldwide estimations here. If we see what's going on in Europe, the different colors show the percentage of obesity rates, and we see here the more dark colors are where it's more than 28%. And the lighter colors are in between. So if you see the countries that have higher rates of obesity, you have the UK here, you have the Czech Republic, Hungary, Turkey. And if you see who gets the surgical treatment, it's not the same countries. So here we have the Scandinavians that have the possibility to have surgical treatment, and that's why explains these New England trials that we had are all from the surgical registries on surgical treatments. We have France here, and most of them are surgical treatments. We see sleeve gastrectomy and Roux-en-Y gastric bypass. There is kind of an imbalance between the need and the offer. So if we see, again, this is the population distribution with the BMI in the UK, and you see here that most people are healthy weight or overweight meaning between 25 and 30. And then you have obesity, 30 to 40 BMI, 25% almost. And this is mostly the target for endoscopic treatments. Above 40, we know this is for surgery. But in this area here, we have diets and lifestyle interventions as well as endoscopic treatments. So this is the portfolio that we have. So we have the standard of care, over BMI, 40 or BMI, surgical, which we have the sleeve gastrectomy, the gastric bypass, as I told you. Still duodenal switch, but mostly it's these two interventions here that have good results, but we know the complication rate, which is high, and also the long-term quality of life that can be an issue in these patients. We have this is not standard of care, but it's commonly done still. So the laparoscopic adjustable gastric band has long-term results, but again, a lot of severe adverse events, and we have to remove these bands in more than 30%. And the intergastric balloon, which is an endoscopic procedure, very fast, but it gives good results, but temporary results. And finally, all these are the different endoscopic modalities that we have, and we'll see this further on in the slides. But before, this was a very important paper in GIE about how to define endoscopic treatment, how to define that it's efficient. And it's based on weight loss, so it has to provide more than 25% of excess body weight loss or more than 5% of total body weight loss at 12 months. There must be a difference between a primary, meaning the endoscopic modality that's primary for weight loss, and control group. Control group can be sham, but also control group like diet and lifestyle interventions, but this has to be more than 50% of excess body weight loss, the difference. And if it's a non-primary, like we'll see for metabolic endoscopy for diabetes, this is not only for weight loss. Weight loss is a secondary measure, but it's mostly to decrease insulin resistance. And here we also put a threshold of 5% of total body weight loss. And why not excess? Because some of the patients that will be included will not be obese, will have maybe a BMI between 25 and 30. Also, safety is important, so less than 5% of severe adverse events are required, and also the possibility to extend this treatment to class 1 individuals means 30 to 35 BMI. So what do we have as endoscopies? So the balloon, this is widely available. There are many devices. Some are adjustable. We can fill it with fluid or gas. Some are inserted with the endoscope. Some are swallowable. They are inserted in the gastric fungus and give this sensation of satiety. The correct position is endoscopically controlled. It's easy to remove, and it can stay between 6 to 12 months, but has to be removed at 12 months. And these are the results, and it's been shown that it gives the difference is more than a placebo at 1 year, but the problem is that weight regain is the rule in this setting. Another new space-occupying device, which works a little differently, is this transpyloric shuttle. It's called the Bobaro Nova, which is a silicone shield here in this, that's put in this, that's filled with a coiled cord of silicone and gives this kind of rugby balloon shape. And it will block the pylorus intermittently, as we'll see here, when the stomach is filled, and the peristaltism will move it towards the pylorus. And this can remain as well, like the balloon, 12 months. And the pilot studies showed good results with excess body weight loss of 31% and also 50% at 12 months. But we still need more data on this device. So what about the Shuttering devices? So these will mostly work on reducing the capacity of the stomach. So we have 3 different approaches. One is around the scope, so meaning you have an overtube device, and the pediatric scope will be introduced in this overtube device. Along the scope, meaning that the device will be used along with a standard scope, and on the scope, the device is clipped on the scope, and you need a therapeutic scope. So one example of the suturing device around the scope is the pose, where you have this device, which is like an overtube with 4 channels. You will put a pediatric scope here that will give you vision, and this will help you with forceps and a tag insertion device that will place several single plicators in the corpus and the fundus of the stomach. There was a comparative trial with a sham arm. We see that the total body weight loss was not very satisfying. It was below 5%, the 5% threshold that we saw. Procedure time was not very long. There were no severe adverse effects, but the primary endpoint, the 5%, was not reached. And it was suggested that maybe these surgeries were not important enough, so maybe they were not serosa to serosa. So this is the other suturing device, which is the Andomina. This was developed by in our department, Vincent Huberty and Jacques Davier, with the collaboration of engineers. And it's a platform that it's fitted on an endoscope and is assembled inside the stomach with a system that will allow the grasp of the tissue, the mucosa of the stomach, to give a plicature and will add a tag with a preloaded needle. And the idea is to put 7 to 9 tags. The first pilot study showed interesting results, and it was a safe procedure. So the multicentric efficacy study finished now and was published. We have an excess body weight loss of 31%. which is again above the 25% of threshold, which maintains at 12 months. There's no serious adverse effects. And we saw in our patients this does not compromise later surgery. But of course, as all these procedures, that is, results are better if they're coupled with a good patient follow-up. And the randomized control trial is just finished now. The results will be out very quickly. So it gives you a restrictive surgery in the stomach, will reduce the size, limit distensibility, and increase satiety, early satiety. So 5 to 10 tissue approximations are done, and still in this, the next areas of research will be to assess if there's a long-lasting tissue approximation, because probably this was the problem with the pose, that this was not long-lasting and not deep enough. That the volume, what is the volume restriction compared to surgery? How is the quality of life? All these long-term results, and of course, to again to be able to provide a safe technique. So the other suturing device that is very well known is the Apollo. This system will be attached to a dual-channel therapeutic scope, so you need a double channel, and it will provide the running stitches that are placed along the running curvature, as you see here, and will reduce again the capacity of the stomach. There are a lot of studies, mostly are retrospective studies based on prospectively collected data. This was the latest meta-analysis with more than 700 patients, 8 studies, and they have very good results. A total body weight of 15% and 17% at 24 months, and 2.2 severe adverse effects. The fact that it needs a double channel endoscope is a limitation because not everybody has this type of scope, but there's a single channel version which is being developed. But there's no sham, no controlled trials, and even with a control group with lifestyle intervention, for example. And there's only one retrospective comparative trial with laparoscopic surgery that showed that, of course, laparoscopic surgery had better results regarding weight loss, but there were less adverse effects with the endoscopic approach. So what are regarding the suturing device, what are the challenges we have ahead? First of all, the patient selection. We know that 20% are non-responders, and the idea is how you predict which patient will respond better, a bit like when you decide between a Roux-en-Y gastric bypass and a laparoscopic gastroplasty. So the suturing pattern is still under evaluation. We try to find the mechanism, and maybe that will help us more in adapting this technique or selecting the patients. Is it volume reduction, delayed emptying, or motility impairment? Diet and follow-up is very important in this setting, and maybe combination therapies will be standard of care in the future. So this is another type of endoscopic device, which is the Aspire. It's like a percutaneous endoscopic gastrostomy, and it's an implant that will pump and drain the stomach after the meals. This also had a comparative trial with a control group that showed we see that the BMIs are very high here, more than 40, and they had very good excess weight loss results, and not important adverse effects. And this was the only endoscopic device that really showed that there was a lifestyle change. There was really a consequence, a change in the diet and in the way the patient takes his meals. So the other two endoscopic devices are the endoscopic sleeve. So we have the proximal sleeve. This one is attached to the cardia, and it gives like a endoscopic bypass. It mimics the bypass. It requires laparoscopic control to attach this, to anchor the sutures. And there have been small feasibility studies that, of course, have to be confirmed. And this is the endo barrier, where the sleeve was attached further down in the pylorus. This initially had given good results, but there were many severe adverse effects, and the FDA multicentric trial was stopped for this reason. Finally, another type of endoscopic treatment, which is a mini bypass with magnets, has also been described, where it requires 2 endoscopies to do a rendezvous, one from above, one from a retrograde approach, and the magnets are put. There is a bypass, and we have a small feasibility study that showed there was weight loss, but also there was a glycemic improvement, probably because of the duodenum, which is bypassed. And going from that to the metabolic endoscopy field, so we know that bariatric surgery with gastric bypass has showed weight loss, but as well a clear improvement of metabolic disease like diabetes. And this happens independently of weight loss, because it's the first days after the surgery, so the surgeons are already described this. Probably the fact that we bypass the duodenum will improve insulin resistance alone, and this is because this duodenal mucosa probably changes, is altered due to the diet, which is high in fat and sugar, and probably alters the hormonal signals as well, which will lead to insulin resistance. So if the question, of course, pops up, if we can bypass this, if we can change this, can we have an effect on other metabolic diseases like diabetes and NASH? And these were the first trials of trying to change this duodenal mucosa to this abrasion of the duodenal mucosa in rats. And they showed that there were effects in the oral glycemic triangle in the rats in the group where there was duodenal mucosal abrasion compared to a control group. And this was based the system of duodenal mucosal resurfacing. And this is an endoscopic procedure with a balloon that will inject saline and submucosal, and that with thermal injury on the duodenal mucosa will remodel it. So this was one of the multicentral trials that was published in Gut, where we showed that the first cohort of 37 patients, they were diabetic patients. These were the glucolate hemoglobin levels. You see that the BMI was 32, so they were not very obese. They were, many of them were only overweight, and they had a very good results regarding insulin resistance, fasting blood glucose, with a small weight loss finally. So this could be a promising tool for juggling this insulin resistance syndrome, and maybe not only diabetes, but only NASH, polycystic ovary syndrome, and who knows, maybe even vascular diseases. So this is an overview of all these different endoscopic techniques that we have. You see that they're not all the same. We have a different effect on weight loss. Some of them might have a diabetes effect. They're not all temporary. It's very interesting to see long-term results, to see the permanent results. But we're still trying to find a place for these techniques. So what about in the future, how to invest resources? First of all, prevention is the first line, that's for sure, and multidisciplinary approach is the priority. In all these trials, a control group with lifestyle intervention is very important. So about restrictive endoscopic surgical procedures, engineering is important to make it simpler and faster. Long-term outcomes to see if these plicatures, they stay, they maintain, and also to see the markers of effectiveness to develop these tests. Prospective trials are important because retrospective trials, we know that will underestimate adverse effects and maybe overestimate the results. At one point, we'll have to define indications for reimbursement and also define the criteria for use, maybe the first surgical approach for these patients that are between 30 and 35 or 30 and 40 of BMI. What about implantable device? Here, safety is a primary concern because this has to stay in place without complications. Duodenal mucosal resurfacing, here there's a lot of work to be done regarding translational research to understand if and how it works. Engineering, again, to make it simpler and faster. Maybe combine it with basic research and see if maybe a stem cells implant can help. And it could be a paradigm shift in the treatment of many other insulin resistance related diseases. And finally, the anastomosis, still we see if this is safe enough, it can be controlled. We have to bypass a restricted area of the small bowel and not too much. So we this still needs a lot of further research. And finally, all these techniques require specific training. All the studies show that these were very effective with low adverse effects, but they were performed in highly expert centers. So before this can be generalized, safety should be assured and training is mandatory before before these devices are overtly commercialized. It always shows that innovating engineers and physicians working together can have great ideas, and of course the most important is patient involvement in the therapy, and dedicated apps can help us achieve these aims. So we see that many options are available in the endoscopist. These are probably addressed to patients who have between 30 and 40 BMI, which for the time being, most of them are untreated. There is no gold standard yet. These endoscopic therapies are important that do not compromise further surgery because, as we said, this is a chronic disease. Duodenal resurfacing will have a metabolic therapy beyond weight loss and maybe beyond even the digestive tube. Education of the patient is a key because the procedure alone will not work. So lifestyle intervention is very important. And of course, multidisciplinary approach for the patients tailor-made with a close follow-up. I thank you for your attention.